Hi, everyone. Welcome. Really excited this week to have in studio Rick Michel, who is CEO and founder of Transtreme. Rick, so happy to have you today. How are you?
Doing well, Shannon. Thank you for having me. Good to see you.
Awesome. Good to see you too. We've known each other for a long time, but I know my audience needs to get to know you too. And so would love to have you just talk a little bit about your company, your experience.
Sure. Thank you, Shannon. Once again, great being here with all of you. As you may recall, my background is that of a cardiology nurse practitioner. Many people don't know that, but I grew up in the Deep South. I trained at the medical centers in Houston as well as in Birmingham, Alabama, and actually practiced with a major cardiology group in Dallas for several years. After doing that, after spending some time there and really enjoying that, starting a heart failure program, doing some other business ventures, I actually spent some time in the pharmaceutical industry where I had the opportunity to have the best of both worlds. I was able to practice and see patients on a part-time basis, but was also working in a medical affairs role in Texas, which then afforded me the opportunity to climb the ladder, as they say, realizing that I could learn a lot about business by going through the pharmaceutical avenue. I spent some time with a couple of major pharmaceutical companies in marketing, sales, operations, even spent some time in China. And upon returning from a project in China, I felt it was time to go ahead and start Transtream. So this was about 2007, 2008. Transtream is an interesting development. The funky name Transtream actually comes from our original business model where I co-developed an imaging technology, trans meaning across, stream, a spin on the traditional spelling of stream, like streaming images, because me and my then business partner were compressing images, echocardiograms, MRIs, a number of other things that was a little bit ahead of its time. Obviously, we have a much more integrated and developed technology now. And that really started to take off. But thanks to the housing crisis, you'll recall in 2008, 2009, which hit us pretty hard here in California, where we both reside now, I had to transition the company over to a different model because we weren't in a situation where we were profitable at the time. But once again, the old adage where you make lemonade out of lemons, if you will, blessing in disguise, whatever we want to say here, because it was then I was exposed to the Medicare risk adjustment model.
I think that there's so much there. One, that your company's been around for such a long time. And then also too, hearing about how innovative you guys are. And I know we're going to talk here in a little bit about your model, but then also too, I have to say, I really appreciate the authenticity. And then you're sharing just how the Medicare Advantage market, the healthcare market is changing. And then that varied experience that you have really allows you to pivot and be able to provide services in a lot of different ways. Why don't we spend a little time talking about Transtream, the as it is today, the visits that you offer, the kind of work that you guys are doing? Because I know, and I hope to get to share some of this in a little bit, that I've been able to use your services in the past in a lot of different ways. But I think our audience would appreciate hearing about how multifaceted and varied you are too. So maybe you can talk about just some of the projects and the work that you're doing today in this new company.
Absolutely. So thank you, Shannon. Going back to what I was saying, where we hit a snag with our original business model, but we're able to turn that into a very successful business model and benefiting many shareholders, including but not limited to, obviously, Transtream and our business partners, our clients, certainly our patients, physicians, among others. But it's a very unique model, right? Where I was one of these nurse practitioners working for one of a well-known home vendor, as they're called in the industry, right? Going out and driving all over Southern California to see patients in the home, patients who I knew nothing about, where I had no information on these patients. It was a blind visit, where patients were skeptical of someone like me coming into their home, someone they had never met, who they knew didn't have a relationship with their physician. And there really was no training or education on the Medicare risk adjustment coding and documentation model. I was intrigued by this. I was starting to teach myself more about this. And then it was at that time I said, let me dig into this a little bit more. Started talking to some of my physician friends who said, hey, Rick, you know, those visits you're doing, the medical group or the health plan is trying to get us to do those visits, but I don't have time to do this. This is not what I went to medical school to do. Then those discussions led to, okay, so when you're not doing them, doctor, then it gets outsourced to these home vendors like the one I'm working with. And I shared with them my experience, my observations, and maybe most importantly, my concerns that even if my recommendations or note ever made it back to them, that they would probably not take action on any recommendations coming from someone they had never met before, to which they agreed. So it was then that we were able to really take off with this idea of what's called an embedded model, where even after going out to build one of these, I call a broken home visit model for another company at a later time, I still knew that I was headed down a road of a model I didn't believe in. So talking to some of those physicians and then collaborating about the idea of, hey, why don't we just put nurse practitioners, including myself, in physician offices, embed them in the physician clinics or offices around town and have the patients come to us, come to their own PCP's office, a known, comfortable environment where they would see a nurse practitioner like me or many others on our team on a regular basis or once a year or more frequently if needed. And that would really set up for some real advantages to all shareholders or stakeholders where patients could come into a known, comfortable environment. The nurse practitioner would have full access to the medical record. So we're not guessing about diagnoses. We're not frustrating the patient because we're asking them questions that we should already know the answers to. In fact, it's just the opposite. We have all that at our fingertips, able to data mine, to look at the patient's history around their diabetes, high blood pressure, have those very meaningful conversations, educate, coach, and truly add value to that patient's care during the visit. And of course, along the way, from a coding and documentation standpoint, documenting those medical conditions that truly and accurately reflect the burden of illness of those patients. Out of that, it was quite an eye-opening experience. This dates back to about 2013, where we kicked this off with a major MSO here in Southern California, overseeing 13 IPAs across all of Southern California, where it took off. It was crazy how fast it took off, Shannon. Me, myself, and the first couple of nurse practitioners on our team found out was A, the patients would come to their own doctor's office. B, while they were a little bit skeptical or suspicious at first, once they saw the value of the visit and said, Rick, I'm sorry, I almost didn't come in. I thought this was going to be like that person who came to my house last year and just asked me a bunch of silly questions. In fact, this is one of the best visits I've ever had. Not surprisingly, again, full access to the patient's record, the ability to set aside 45 minutes of time, if not a little bit more, to truly add value to that patient's care, not to ask questions around PHQ screening, pain scale assessment. All those things are, of course, integral parts of the visit, but to actually get that patient up on the exam table and to listen to their heart and lungs, to pull off their socks and shoes, to really add value from a clinical standpoint, knowing that patient should leave there feeling like this is one of the best visits I've ever had. Or as I always say, if I'm not the person prescribing their medications or treating their conditions because I've stepped out of that world, then I need to make sure, want to make sure that patient leaves there feeling like there was real value added to that visit. So that really took off. Next thing you know, it's not just Rick and two other nurse practitioners. There are 10 of us, 20 of us, 50 of us, 100 of us. And it's not just now, 12 years later, Southern California. We worked in 30 plus states. I just got back from Alaska working with one of our nurse practitioners there on a value-based care arrangement or partnership with one of our clients there. We've done so many more things, Shannon, some of which, of course, we've opened up wellness centers. We do health fairs, transition of care programs, chronic care programs. So Transteme is a group, simply put, it's a group of clinicians that found a way to address what, unfortunately, 15 plus years ago, or fortunately, depending how you look at it, still to this date, is a severely broken model. And we've been blessed.
I just have to share too, because I've had the good fortune to work with you over many years. And I think one of the things that always impressed me in that embedded model, I know you guys do all sorts of visits. And so, want to give you a shout that you've always been flexible partners. I know during the pandemic, we set up testing sites, we've done vaccination sites, you've done health fairs for me in the past where we've done screenings. We've done quality campaigns. You can do home visits, but I think the embedded model is really special, especially when we look at the guidance that we're getting from CMS and OIG. And so it solves so many things. You're getting to document in the physician's EMR, which they love. You're right down the hall from them. So if you need to pull a doctor in because you've seen something, you can do that. And so there's additional continuity of care and a lot of the communication that's required. I like what you said too about it's not just questions, that you're actually able to lay hands on the patient so the patient feels like it's a meaningful visit for the purposes of doing that full assessment. Of course, I know you guys are open to designing that, but then also too on closing quality gaps. And then too, like you said, getting the patient in to the physician's office so that they feel that they don't really see a differentiation. Again, it's enhancing or continuing and promoting that continuity of care. Other groups, though, have tried to do these visits. What do you think? And I'll be honest, and I know I sound biased right now, and I don't mean to. And I've had the experience of using some very good vendors or some very good partners around these visits in the past. But I will say emphatically, I think that you guys are the best at doing those embedded visits. What is it that you think that makes Transtreme better at it than other groups out there?
Yeah, thank you, Shannon. Thank you for those kind words. We are very blessed. I personally am very blessed as well to be able to surround myself with such a great, amazing group of folks all around the country. It's interesting because our model is one that takes great pride in being very flexible, being very nimble. And in fact, that was one of the reasons why this MSO I mentioned earlier on took a chance on us, if you will. They said, Rick, you're a clinician, right? You're going to be able to resonate with physicians. We don't know them. They don't trust us. They're skeptical of us. You go out and build a program because you'll be able to connect with them. You go build it. This is what you do as a builder with a history of building successful programs. So I was glad to take on that role, and it was very refreshing because certainly, not that we didn't know this already, but what was learned or reinforced as I was making my way out and establishing the program across Southern California, meeting with physicians almost on a daily basis, was that every physician or every clinic is different. If you've been in one clinic, you've been in one clinic, right? Not just geographical differences, but cultural differences, expectations. The physician who has set expectations around what patients should get what screening tests at what age, right? Even knowing what the national guidelines are, of course, there's some variance to that based on physician preferences, et cetera. So it's the ability to go out and understand our customers, not just our MSOs and our health plan partners, the IPAs, but the actual physicians and the patients who they service, and then modeling or adjusting our program to fit their needs and their expectations, overcoming the concerns they have. Look, if I had a dime for every physician who thought maybe we're coming in to take over their patients, or that maybe their patients only wanted to see them, when in reality, their patients really want to see whoever can provide great value and can make a contribution to their care, or that the visits are going to create more work for physicians. None of that is really true because, as I always say, these are wellness visits. If there were patients who had active chest pain or shortness of breath, they wouldn't be coming to see me. They would be coming to see the doctor for a fit visit. But you hit a good point, right? One of the big advantages is that we're right there working in the physician offices with the physicians, or they're doing their own thing in the next room while I'm doing my thing. And so now there is a true facilitation and a collaboration of care. Obviously, for the case that most often comes up when there is something that needs to be addressed, an uncontrolled blood pressure or a new onset atrial fibrillation, I don't have to say, "Hey, Shannon, we don't know what to do, right? Because your blood pressure's out of control." Instead, I say, "Hey, Shannon, your blood pressure's up a little bit. I see in the chart here you got a little white coat syndrome historically. Let me go and talk to Dr. Decker. I hear her seeing her patients in the next room." So now, both in that situation and throughout the day, while we're crossing each other in the halls, we really are facilitating and collaborating care. At the end of the visit, I can say, "Patient Shannon, look, you really enjoyed the last 45 minutes with you. We talked about your diabetes. Great job. Keep up the good work. We talked about your diet, exercise. We went over all those other things that I'm concerned about in our seniors. Are you falling at home? Any uncontrolled pain, any depression, any social determinants of health issues we needed to address? Oh, but you haven't had labs in almost a year. Let me go ahead and just order your CBC, CMP, lipids, and A1C if you're diabetic. Let me order your mammogram, Shannon. Let me order your bone density. Go over to the imaging center with your ID and let's get those things done." So we found that we're able to not only do a great job with the Medicare or the risk portion of things, but obviously from a quality measure side, we were able to try to get those gaps closed right at the point of care. We found, because of the value we were offering to patients as well, that when we said, "Go get your mammogram, your bone density labs," guess what? They went. And we knew that our numbers were higher than when physicians ordered those things, probably because, again, the patient was open to and following our recommendation lead because they had such a great experience during the wellness visit itself. I want to be very clear, though. We mentioned home visits briefly. Unfortunately, one of the misperceptions of Transtream in our model is that because we are the founders of the core embedded model, we have not done, or we've done very few home visits. It's just the opposite. Actually, we've had a huge transition to doing more home visits, not only for our MSO or IPA partners, but also for health plans. And when those first few patients that we were seeing in 2013, or when we first started in 2013, obviously not all patients could come in. Some of them don't drive. They're too frail. They're in assisted living facilities. At first, I said, I don't know, not my problem. Call that home vendor. But I thought about it. So wait a minute. I think we can fix that broken home visit model. And we did, Shannon. And here's how. I asked for the list of patients who the schedulers in the office were calling. I would call those patients personally on the way home. And I found out a couple of things pretty quickly, Shannon. Number one, those patients answered the phone. Why? Because they knew that I was associated with their doctor, Dr. Decker, right? I wasn't calling from some outside home vendor they never heard of. Number two, when I would go to see them the next day after clinic was over, they answered the door 95% of the time. It wasn't a no-show like I had experienced when I was with that home vendor. Number three, because of my relationship with the physician, with the MSO, the IPA, I had access to the medical records. So I could go into Shannon's home as a patient, say, Shannon, I'm sorry you don't drive anymore, but let me open up my laptop. I could open up my laptop, get it right into your medical record. And I found that I could actually do the same thing that I would have done in the clinic had Shannon come to the clinic. We prefer to see her there for various reasons, of course, but we were able to do the same thing we were able to do in the clinic, even when going out to complete a home visit. So that has garnered a lot of attention over the last few years as the health plans started coming to us and saying, hey, we haven't been happy with our home vendors, their outcomes, the quality of work, the inability to close quality measure gaps, retinal exams, A1Cs, KEDs, and lots of other things that are obviously a meaningful part of a comprehensive risk and quality program. We can do all that. Again, it's been very refreshing to be able to come to the table again as a group of clinicians who don't say, no, we can't do this or we can't do that. It's no, we're nurses and nurse practitioners. We figure stuff out. And it's not just going to be one way or the highway. Let's figure out where the unmet needs are that our partners are experiencing, and let's find a solution.
I love that. I know you talked about the embedded model at length and then the home visits that you can do. I know you also do telehealth. And so you have the ability to really figure out what the needs are of the particular health plan or group and provide those services. So you mention a lot about you doing the work, which I think is so important because then you understand the market. But talk to me a little bit about folks that might say, with all those different models and all the work that you're doing, is it truly scalable? And so, how are you able to work? And maybe you can talk about how the training that you provide to your team so that they're replicating the work that you did in those early days so that quality is carried throughout the work that you're doing across the country for the various groups. Because I really do think, like you said, that differentiation and being able to address the unique needs is important because geographies, whether it's a health plan, if it's a rural area, a city, southeast to northwest, are all different and have varying needs. But how do you, in a scalable way, demonstrate and reproduce those great results across the country and through your team?
Yeah, great question, Shannon. Thank you for asking that. So again, another misperception of the organization is because as a practicing clinician myself, I'm oftentimes using me and my experiences with patients and with our partners around the country, because this is one of the few times you'll see me sitting behind my desk. We are an in the trenches group, if you will. We want to be out there in the trenches with our patients, with our partners, the physicians, because that's what we do as clinicians. Certainly understanding that there's no way to build a scalable program if yours truly is the only one seeing patients and going everywhere all the time. That is not our model, and I want to be very clear here. One of the things that I was able to do successfully when I was in the pharmaceutical industry was I found out, while I'm not the smartest guy in the world, I was pretty darn good at identifying talent and in developing that talent to help those folks to get where they wanted to go. Recognizing that I, as a nurse practitioner in Texas a few years ago, when I was in practice, thought I could do so much more than just see patients. Not that I was just seeing patients because I was offering value, but I wanted to do more. So I knew there were other folks out there like me, other nurse practitioners who could do so much more and wanted to do so much more, but maybe felt that they did never had the opportunity to develop the business side or to do other things. So to answer your question simply is yes, what we do is we are very good at identifying and hiring talented nurse practitioners, nurses, medical assistants, which we'll talk about in a minute. And then obviously making sure that unlike that home vendor that I worked with, we really do a great job giving them the tools and resources they need to go out there and be successful. So it's not, hey, here's a cheap laptop, good luck, God bless. It's, hey, when you come on board as a nurse practitioner, whether it's locally here in Southern California or other markets, we're going to take you under our wing. You as a nurse practitioner will spend several days with one of our existing nurse practitioners. moving you from an observational role to a fully independent role. That could be 5 days, it could be 10. It's a very tailored model. We love new graduates because they're like sponges. They want to learn, they develop, and they're able to go places as well. And all along the way, we're coaching them, we're teaching them, nothing in a punitive manner, but instead a coaching, collegial, collaborative relationship. We're developing that nurse practitioner. Now, going back to your question, if that nurse practitioner wants to do more, if that nurse practitioner wants to be a leader in this company, that's what we have been able to do. That nurse practitioner says, Rick, I want to do more. Great. Let's develop you to be a leader in this organization. And that's what we've done successfully. Do you want to lead a team of nurse practitioners in a geographic business unit, or like Alda in San Diego, I'm thinking of, who's been with me since 2013. He's now managed a very successful team in San Diego for many years. She still sees patients on a part-time basis. Again, so she never loses touch of what our partners are looking for, what our physicians are saying. So she understands exactly what's happening out there. Oh, and by the way, so that those nurse practitioners who she manages constantly have that respect for her, not only as a leader, but as a clinician. So it's been an exciting run for Transteme. As we grow across the country, obviously, we have been able to scale. We have lead nurse practitioners in our major geographic markets, whether it's Northern California, San Diego, Los Angeles area here, Florida. I spoke with Megan on the East Coast this morning. So again, we have done what few thought, but I think few thought could be done. We've been able to do. I'm just a guy who comes in every now and then for that reason, right? I'll step into Michigan next week to see some patients to kick off an extension of one of our existing partners who's looking for help in Michigan. But I will then, along with my other colleagues, identify local talent, hire that talent, develop that talent, and then now that person will be the nurse practitioner or nurse practitioners locally who will then service those patients and our partners for years to come. Great question, Shannon.
Thank you. And we've talked a lot about, I know we've mentioned, but I think it's important to call out too, the different levels of services that you can provide. So maybe you could share not only doing annual wellness exams, but maybe some of the quality programs that you've done. I would love to hear some from the field's experience of programs that you've run, things around chronic care management, but maybe a sampling of some of the projects that you've done over the years.
Sure. Thank you, Shannon. Yes. So again, going back to what we said earlier, right? As a group of clinicians, we go to our partners and say, tell us what your unmet needs are. Let's find a solution, because that's what we do as nurses. I'm thinking of when you and I first met, and you'll recall one of the IPAs under your umbrella here in California, when we first met and we were working together, you'll recall one of the IPAs specifically said, Rick, for years, you and your team of nurse practitioners have been seeing our patients. The patients are coming in year after year. We're completing over 85% of our annual wellness visits on an annual basis. From a coding and documentation standpoint, we continue to be at a high level of compliance and a high level of accuracy and completeness when it comes to truly documenting the burden of illness or burden of risk of our patients. Oh, but by the way, we seem to be giving a lot of the funding that we receive from the work that you do and from other sources. We seem to be giving a lot of that right back, because we have a group of frequent flyers, if you will, out in the community. Remember that, Shannon? The patients who had the congestive heart failure, COPD, diabetic complications, and were constantly bouncing into the hospital. That was also an aha moment for us, because we said we'd gladly like to take on a pilot project that then led to a little bit more of a longer term project where we were managing at any time 50 to 75 patients in the community in this IPA here in Southern California. And we found that we were able to obviously do an initial visit, put that patient to a specific acuity level or a tier, if you will, which then drove the number of visits that nurse practitioners were making to the patient's home, which then drove the number of calls that we're getting from our medical assistants or RNs on the days the nurse practitioners were not seeing them in the home. But then also a few other aha moments is that we were able to not only keep those people out of the hospital, but we got a lot of feedback from the physicians that, Rick, this is taking so much off of my plate, because I was getting those calls from the patients or even from other services who were trying to do this. And it was frustrating. Rick, you've known me for years, my patients already, as do the other NPs who are working with the other patients and the other physicians in the IPA. You don't need to call me when that patient who has a congestive heart failure, acute exacerbation, if you will, needs treatment. Just go ahead and tell that patient double their Lasix for the next 3 days, double their potassium. Do what you need to do, because we have built that relationship now over the years through the Medicare risk adjustment program, to where I know what you're going to do, and I know you'll take care of that patient, and you don't need to call me. So again, it was very refreshing. Aside from that, we've of course successfully run transition of care programs. We do a lot of health fairs. Shannon, you'll recall when we worked together in the past, I think the year before the pandemic, we completed 19 health fairs with one of our partners here in California, where we were doing these health fairs in a high school gym. We were doing these at a church. We were doing it in parking lots in Palm Springs. And not only were we doing the Medicare annual health assessment visit, but in those specific situations where we're not in a physician's office, where I'm not actually ordering labs or mammograms, we would do those. We would take care of closing those quality measure gaps right on the spot, because we carry diabetic retinal exam cameras. We have A1C kits. We have kidney evaluation for diabetic kids. We have FOBT kits that we can share with our patients. Coach, not just drop a kit. We don't mail kits. We coach that patient with that kit. We work on the paperwork for and with them. We make it easy for them, and we let them know that the expectation is that they're going to complete this. Quality measures are another discussion. You asked a little bit about that, but it's really a big turning point in our organization now as well, because we are doing so many more visits outside of the pure embedded model for the health plans, at health fairs, at our wellness centers, which are freestanding facilities, physician agnostic, that we've opened up, where let's say a group of physicians or a partner needs our help, wants our help, but they don't have space for us to come in. We have wellness centers in San Diego, here in Chino, in the Chino area, in several other states, where we can bring those patients into that central location, do not only the wellness visits, but also do gap closure, because we have the DRE cameras, A1C kits, FOBT, bone density machines. So again, we can't be everything to everybody, Shannon. We have to be careful there to make sure we have not only a longstanding viable organization, but that we are offering all the value that we can. We don't ever want to compromise the quality of care. And you've probably seen on some of my social media postings recently, I'm using more of the tagline, it's about quality, not just quantity, because again, we know we can scale. We know we can see hundreds of thousands of patients like we have now for several years, but we want to make sure that we never compromise the quality of care that we're delivering to those patients and to our partners.
I think it's refreshing. And just in talking about over the last year or so with V28, and there's been a lot of concern in the industry, and just the fact that you not only have breadth of service, but depth of care. And so being able to go out into the home, and it's not just about risk adjustment anymore and doing the annual wellness exams. You need to make sure that you have continuity of care, which makes sense. The quality gap closure, but then also too, just going back to what you were saying about the congestive heart failure and even our COPD exacerbations. We know that's an area that can be controlled and relatively easily controlled. And I know I remember that program and using your team to go out and see patients in the home, as opposed to having them show up at the ER where they might still not get the services they needed. And so it was a more efficacious appointment, if you will. And that's what I meant by depth of service and really addressing total cost of care. But I also can speak to those health fairs and even the home visits when you were doing quality, you would do quality gap closure for us. So even if we just needed you to do the DEXA scans, or we just needed you to go and do the diabetic retinopathy, I know that you were always great partners at that. And then I know you mentioned the wellness centers and the health fairs that we would operate. And I always thought that those were great too. I still remember the ones, I think it's been 15 years now, in Palm Desert. And we would have bingo and the physicians could come and give a talk. And you guys were great about staging and even working through and seeing patients, and just the way that I know I'm going to get to interview Stephanie later, and she's the master of logistics, but just how you guys were able to stage patients and really be able to see as many patients as possible within a short amount of time that we had it in that particular day. And you were able to close so many gaps.
I think we saw 93 patients at a church just before the pandemic. We had 115 or 120 patients scheduled for health fair. I think 93 of them showed up, Shannon. So it was myself and about 5 or 6 other nurse practitioners. And throughout the day, as these patients, some of them scheduled for the completion of the wellness visit during the health fair, others who were walk-ins, which was fine, we were able to complete, I believe, 93 wellness visits. And you're right, those are so much fun, not just for the patients, but for us. There's bingo. I remember we did one in Hawaii a few years ago. There was a Hawaiian ukulele group, a senior ukulele group. There were giveaways, raffles. I think someone from our team put together a little spin board where patients could get education on hand washing and other things, depending on where they landed on the board. So just a lot of things where we've really truly been able to integrate coaching and care. And as you said, what can we do from a care coordination standpoint? How can we add value, especially now in a value-based care world? We're working with several value-based care partners in nephrology and other areas, dialysis centers and outpatient nephrology clinics. So again, it's all about unlocking that value. And early in your commentary a moment ago, you mentioned with V28 and with the facilitation of care, maybe with oversight and concerns around compliance. I can't agree more. Let me be very clear, Shannon. I've had some meetings in Washington recently, right, where I'm pushing for the continuation of the risk adjustment model. Risk adjustment needs to stay. The dollars, I'm speaking as a clinician, not just as a business person, but the dollars should be aligned to those who need it the most. Because as a cardiology nurse practitioner and someone who specializes in heart failure and hypertension, high cost areas with significant downstream consequences, implications, and other, without a doubt, those are high cost centers, if you will, for our partners. So we want to make sure we do a good job, not only helping to align the dollars with the burden of illness or burden of risk that the patients and our partners face, but also making sure that we are doing all that we can to keep that patient healthy and well. The true facilitation of care, which is what DC is looking for. And I'm okay with that. Look for it, because I'll be the first to raise my hand and say, the system is broken. There's a lot of fraud, waste, and abuse, and we have to see an improvement in the facilitation of care. Great, document the medical conditions, but let's make sure that we're having a conversation with the patient's PCP specialty, that we're ordering appropriate screenings where necessary, ultrasonography, where we're coaching the patient on the importance of foot care and fall risk if they're a diabetic who has neuropathy. So all of those things need to be and must be a part of the patient visit. I hope you can see our passion here, because this is how we feel as an organization. Again, it's not about quantity. We can see hundreds of thousands of patients, but we never want to compromise the quality of care that we deliver to our patients and our partners.
Speaking of volume, and I know I didn't ask you, I didn't prep you for this, but just curious, over the years, how many visits will you say, how many patients have you seen?
Without a doubt, we've seen several 100,000 patients over the years, Shannon. So again, I think the perception is that we're a small organization. Look, we don't have fancy websites. We're never going to put on our websites that we have thousands of providers across the country. That's not true. I don't think anyone has thousands of providers except for the big name brands that we can talk about, major health plans, of course, which I think we know all too well. That may be the case. But others, whether it's those who have tried to replicate what we do or those in a similar space, if you will, are touting thousands of providers. We don't have thousands of providers. We can get there. We want to get there. But again, we won't do it in a manner where we're misleading others. And maybe that is in part maybe in part that hurts us, because we want to be very clear. Yes, we could flip the switch and have thousands of providers tomorrow. Again, we never want to compromise the quality of care we're giving. And when one recognizes and understands our core model of identifying an unmet need, coming into a geography if we're not already there, our ability to initiate a program, scale that program, and really build a nice long-term program for our partners is what we do and what we do well.
I think you're being very humble, and I'll just share with you, I would agree that you do scale well, and I'll just add some examples of my experience with you. And I've used a lot of different groups over the past, and some, I would agree, provided good service. But I think what made you guys different is that you really did listen to what we needed. And I know, and for those out there that do operations, you'll know what I'm talking about, that sometimes you might contract with a group and they'll come in and they'll cherry pick a particular area and they'll look for the most densely populated geographic areas. They'll drop in, they'll schedule as many appointments as they can, and they get out. But the truth of the matter is, those patients that we need to see might live in more remote areas. And so folks that would be in border towns or maybe in, again, those rural areas that are hard to get to, where there maybe isn't as many physicians to go and see or as a sophisticated healthcare system. And I know that you guys, as good partners, were always great about going into those areas and really driving to see those patients and to provide the care and the close the quality gaps and do the annual wellness visits that we needed. And so I know that was something that I always appreciated in how you supported us. And I'm trying to think of, I can think of some recesses of the country that were very difficult to get to, that you were able to get to that other providers told us they couldn't do. And I'm trying to think of any area in the country that you couldn't get to. And I know I sound very biased right now, and maybe I am, but honestly, I can't think of any. You guys are in Hawaii. I know you mentioned Alaska. I know you've done work in Michigan and New York and Florida, Connecticut. So all along the Eastern Seaboard, United States, Texas.
Let's not forget the Rio Grande Valley as well. There's so much talk these days, and I won't get political here, but we certainly understand all that's happening along the Texas and Arizona borders. But I think about our work in Laredo and McAllen, those border towns. And certainly as someone who grew up in the Deep South, certainly blessed. I didn't grow up poor, but I certainly didn't grow up wealthy. And so I know the people that I grew up with in New Orleans and people all across the state of Texas having practiced there, where my wife was originally from. Going down to the Rio Grande Valley, myself and the other nurse practitioners who service that area realized without a doubt how much unmet need exists. One simply needs to drive along from McAllen along the border all the way out to Roma, 45 minutes an hour away from McAllen, to see how much diabetes exists out there, how those patients feel that they've been forgotten about, they don't have access to care, they feel that they want help, but no one's willing to go out there. You're right. What I always say is, why would we withhold our services if there are patients in Laredo, Texas, no different than Los Angeles, California, or New York City? Let's go help them. Let's find a way to go out and help those patients. Again, we're not going to withhold our services if there's an unmet need out there and there's a partner that wants to engage with us and they're willing to listen to us and understand our model, understand that we will come in and build it. We're not expecting our partners to be clinicians or to be able to build this. We want them to build it with us, right? And to make sure we are collaboratively working to address those unmet needs. But you're right, Shannon. I'll share one story with you. So we're about to ramp up a new partner or a new contract of ours with a pretty significant health plan across the Midwest. I'll never forget, this partner came to us in late 2023, right after the Thanksgiving holiday, citing that they were working with one of the well-known, if not the most well-known home vendor, but they had a few hundred diabetic patients who had not had eye exams. And of course, we were running out of time, as they say. This was literally the day after Thanksgiving. I heard from them. Without going into too much detail, unbelievably, they were able to get some sort of contract in my hands within 48 or 72 hours to go out and do retinal exams across the state of Ohio. So what did we do? We said, get us the list, which they did right away. We mobilized medical assistants and nurse practitioners to Ohio, a state where we didn't have a footprint at the time, where none of those folks had ever been to Ohio, but one person went to Cleveland, one to Columbus, one to Cincinnati. And in not only in those urban areas, but in outlying areas of Ohio, those patients who needed diabetic retinal exams, we were able to get to, I think the list was about 300 patients. And with the minimal amount of time we were able to send out there, considering it was now December, limited resources, limitations at that time of the year, we were able to get 100 diabetic retinal exams done on a list of about 300. I was disappointed. I thought, in fact, that we would not be able to do business on an ongoing basis with this partner. In fact, they were ecstatic. They said, Rick, we gave you patients that we didn't think you'd ever get to. We didn't think you'd get 20 of them, let alone 100. So we were able to raise their DRE star. We were able to replicate the results on a slightly larger scale in 2024. And now in 25, we have a full risk and quality contract to go into Ohio and hopefully soon the other states that they service in the Midwest, recognizing that, hey, these guys get it done. They move quickly. They're flexible. They're nimble. They'll go wherever the patients are. Oh, and one thing I wanted to share with you, the reason we have a risk contract now with them as well, or risk is part of the contract, is because we did a little side project. Recognized when we went out to these rural areas, these patients weren't just patients who had diabetes and needed retinal exams. They were smokers who had COPD. They were on oxygen 24/7 who had obviously chronic respiratory failure. They had a history of strokes with residual deficits and sequelae. So we were already realizing in our head that these patients were not being accurately coded, or there was not an accurate representation of the true burden of illness or burden of risk that exists in these patients. So again, it's the above and beyond, not just for the benefit of our business, not just for the benefit of our partner, but especially for the benefit of that patient, where even though we went in just to do diabetic retinal exams, and then in 24, we did A1Cs, KEDs, FOBTs, but we also along the way did the extensive coaching and counseling, because that's the right thing to do for our patients. Yeah, have the equipment will travel. If we can get there by planes, trains, automobiles, or other, then let's go do it. That's what makes it fun, Shannon. I don't want to sit behind a desk all day long. How bored would I be? And how bored would our nurse practitioners be if they were doing that? So that's the people we hired. The attitude of, hey, Rick, let's just go get it done. We're starting a new partner in Oregon. Sign me up. Let me start working on my license, because I want to go help kick off that new program and really scale up our model.
I think it's important. I know in working with other groups too in the past, other companies, sometimes the folks that were going out and seeing patients didn't know what they were doing, didn't understand documentation. I know you spend a lot of time, and you touched upon it too, training staff. And it's not just about go out and find these codes because that's what we believe is true for the population. They're actually coached on critical thinking skills, and that you're doing all that auditing and monitoring, but then also to just your experience that you're able to walk the walk and talk the talk, if you will, because you do have that real field experience.
I think you're exactly right, Shannon. We look at the age we're in currently, artificial intelligence, natural language processing, chart reviews, and technology that goes with that. We're not turning a blind eye to that. We know there are a lot of available resources out there. That's fantastic. Anything that can be done to take value to the next level. I think at the end of the day, what we want to make sure we're doing as an organization is saying, hey, we want to use our core coding and documentation, patient-facing skills. Like you said, that nurse practitioner who comes on board is not getting a cheap laptop, and we're not saying good luck, God bless. We're going to take that person, truly develop them over the days to weeks coming, continue to follow them, 100% chart reviews until they graduate from our program, and then continuous random audits along the way by their lead nurse practitioners and our learning and development team who has oversight even above them. But recognizing as well that, yes, while there's a lot of technology out there, you still need and patients still want that face-to-face interaction. They want to know that somebody's talking to them about what they're seeing in the chart, whether it's coming from my own eyes, whether it's coming from AI, natural language processing, or other. And again, let's not forget that we've spent a lot of time talking about care collaboration, care coordination, facilitation of care. That's essentially what we want to do as well. So yes, we're taking the new hired nurse practitioners, we're developing them in the clinic, we're going out and doing home visits with them, we're setting expectations, holding them accountable, we're giving them the resources they need to be successful and letting them know they're part of a valued team that just gets it done. We're also taking them to the classroom. And I don't think I've ever heard of anyone else doing that, but we'll pull them out to the classroom for several hours somewhere in the middle of their training time with us, day 4, day 5, and we will do a full coding and documentation class. And it's not just diabetes and all the complications. It's not just hypertension and heart failure and chronic kidney disease that are associated conditions. It's, hey, what is this world of risk adjustment? How did this come about? What does this mean? What is the interplay of the exchange among the health plans, the IPAs, the primary care provider, all the services that are around what is at the very center of everything, that being the patient. Again, very passionate about what we do and really blessed to have the opportunity to spend some time with you here today, Shannon.
I love that. We've talked a lot about the various services that you offer, but I know that there's more to your infrastructure too. You had mentioned before that you have a call center. Maybe you could talk about the other support that you have around how are you working to get data back to your clients? Are there, if you're not able to get into an EMR, do you have a system that you're doing reporting on? Are you able to submit claims? Talk a little bit more around the other support systems that you have that help your model do what's needed for clients.
Sure. Good, great question, Shannon. Yes. So I mentioned our medical assistants earlier. Going back to when we talked about how we found the solution to the broken home visit model of myself, Shelly, Karen, our first nurse practitioners actually going to the homes after our clinic time was over to see patients in the home. Obviously, as we started scaling the program, Rick and Shelly and Karen couldn't keep calling patients on the drive home. We got too busy. So we brought on Stephanie, we started bringing on others. And then we realized what's one of the things that's really resonating with patients, not just their understanding or not just the fact that they saw us as an extension of their provider, not some outside company. We don't go out and promote Transtreme. We say, hey, this is your program partner, call it your nurse practitioner program. But back to my point in that as we started to grow, we realized we needed more help. I was committed to bringing on people who truly could talk the talk. We wanted people engaging patients by phone who truly could explain the Medicare wellness visit, who could talk about the screening tests we might do, who understood diabetes, high blood pressure, the testing we would do with our patients, including but not limited to depression screening, fall risk assessment. So we moved to a medical assistant group as those who could support our scheduling services, if you will. And we've really, again, along the lines of being an all clinical model, we tried to adhere to that over the years now. And so those medical assistants, in addition to being our schedulers, if you will, and positioned in our call centers, which by the way are here in Southern California. We have one in Dallas. We have one in Florida now. We also will train and develop those medical assistants to do other things. I'll pull them out to go do health fairs where they can support our nurse practitioners, where when we have 93 patients that we're seeing at a health fair in Northern California at a church on any given day, those medical assistants can also do the screenings, testing for retinopathy. They can do A1C test. They can do KED testing. They can even do neuropathy and PAD testing if that's part of what we're doing for that particular partner and for those patients. So again, really giving them an opportunity to shine, to do more than just call and schedule patients and explain the value of that visit, but also allowing them to get to dig in and get their hands dirty, if you will, because they want to develop as well. So, again, we've been blessed to be able to scale this up, lead nurse practitioners in our major geographic markets, a learning and development team, oh, by the way, led by actively practicing nurse practitioners, compliance officers, and all that goes with that. So we do have really a nice infrastructure that we've been able to build over the year. Obviously, I haven't talked about the business side. That's a given with HR and CFO, et cetera. But again, we really made a real business out of this when early on, while we had a fantastic partner as our initial partner in Southern California back in 2013, I think deep down, they, without intention to insult and none taken, was I think that they thought this would be a model that would be limited to a small geographic area in Southern California and nothing more. In fact, we made a real business out of this with our ability to scale, identify and develop talent, and then service our partners to the highest level of quality and care.
I've really enjoyed speaking with you today. Really appreciate the insights. I think that operational leaders out there that are running risk and quality and total cost of care programs, hopefully they're picking up nuances and things that they would want to look for in their program. I think one of the things that's come out in this interview, if I were to look over the whole of it, is that you're really a culture forward company, and that has served you well in being able to really address what your clients and what your patients need.
You also asked Shannon about how we deliver the data. That's a great question. So when we engage a new partner, usually their ask is that we are involved in the scheduling, at least in part, if not in full, right? Sometimes the clinics will do their own scheduling. Other times our partners will ask to utilize our resources in those call centers that I mentioned just a moment ago. That's great. We can take in that data. We have our own infrastructure and full CRM that includes a HIPAA compliant scheduling tool and platform. We can then utilize or put those call centers to work, call and schedule those members, and then the nurse practitioners will see those patients. When they see those patients at the end of the visit, they will go through what's called the checkout process. We will check out that, confirm that the patient was seen. We'll confirm what screenings were done, if any, and if not, why not? Maybe the patient was already diagnosed with vascular disease. Maybe the patient was already up to date with diabetic retinal examination. And we deliver all that back to the partner. As far as the documentation itself, that's a great question. One of the real advantages of our embedded model is that our expectation is that we will have access to the patient's medical record, at least in a read-only manner, because we want to be able to dig in, look at labs, look at consult notes, look at chest x-rays, et cetera, to be able to do our job and do it well. But with that access to a patient's EMR, or like Epic, which is a well-known, oftentimes used EMRs, we will preferably do the work right in that Epic EMR. Open up a patient note, no different than what Dr. Decker would do while she's in the next room seeing another patient. Now the physicians love this because they're saying, Rick, you're doing great work. I love this. And oh, by the way, you're doing it right in my own EMR. So I've got that visit note. So I can see the things that you did. I can see the things that you ordered. I can get the results when they come back. Now, some of our partners like health plans say, Rick, we don't have an EMR, or we will give you a list of home visits or televisits we want you to see. That's great. In that case, where there is no EMR platform that exists, we've adopted our own, as I said, CRM, which does include, again, a HIPAA compliant electronic medical record platform, which is totally customizable. Some of our partners say, Rick, can we put in social determinants of health? Can we add this or that? We'll do whatever our partners want, adjust that template accordingly, and then we'll see the patient. And we can do the note right in that EMR, our own EMR, if you will. We can submit a claim on behalf of our partner. We can submit it under our tax ID or theirs. When we're in a clinic or physician's office and using their EMR like Epic, usually that's because that's done, of course, under the guise of a medical services organization or MSO or an IPA. And they say, Rick, you just do the work. You and the nurse practitioner do your note. When we see that note has been closed, no different than our physicians, we'll go ahead and submit that claim right out of our own EMR. So again, just really reinforcing that there's not just one right way or the highway, Shannon. It's a very flexible model where we dig in with our partners and say, what's the best workflow here? Doing in your EMR and our EMR, both? Are we submitting claims on your behalf? Are you submitting claims and we're going to invoice you for payment? So very flexible model. And we have all those models, among others, in place.
I have another question for you. And I think I hear this a lot, is that there is this perception that folks choose the home visit because the provider groups wouldn't let someone in or they're not going to participate. You obviously are using this embedded model. Maybe you can talk a little bit more about how are you, and I think we could glean it from what you've said thus far, but would love for you to just call it out for us what it is that you're doing that permits you to work in those offices to get the provider engagement, the physician engagement, that they're inviting you in the office, that they're allowing you in their EMRs. How are you getting them to participate where maybe others felt that they had challenges?
Sure. Great question. So I think I touched on it earlier. Physicians are going to have certain preconceived notion or thoughts about what an embedded model might do. Oftentimes it's a negative thought. Like, hey, Rick, this is just going to create more work for me if you're bringing my patients in here. My patients only want to see me. We're able to quickly get through those things. And actually, it usually comes about when we just find a few early adopters, if you will, 3 or 4 or 5 physicians or clinics who say, yeah, come on in, let's give it a shot. And they immediately see the value. They realize, hey, I'm talking to my patients on the way out and they're actually happy. They're coming out smiling. They're happy when they saw the nurse practitioner. And Rick, I heard you in the room. I can hear you and my patient cutting it up. They're having a great time. I said, yeah, when I'm with a patient for 45 minutes, I'm going to learn a lot about that patient. We're having a great conversation. But now, again, we're offering the value to the patients. We're getting them up on the table. So it doesn't take long for the physicians to realize, hey, this nurse practitioner group is actually pretty good. They make me look good because my patients are coming out happy. They take these wellness visits off my plate because I never wanted to do them. I'd rather see 3 or 4 sick patients in an hour, not try to fumble through a 45-minute or 1 hour wellness visit, which again, I don't know how to do these anyway, Rick. This is not what I went to med school to do. And then of course the collaboration that we're doing throughout the day is fun. It's enjoyable. And physicians really have come to respect and value that because I think I would argue just as much as well that I've heard so many times from physicians, look, I know there's somebody out there seeing my patient with this home vendor, but I don't know who this person is. I don't know that I trust them or what they're asking me to do, the recommendations. Oh, that's assuming I even look at their note, Rick, because I don't have time to do that. When you're working right in my medical record, I can see what you're doing in real time. And for years to come now, we're building a relationship along the way, not just between you, the nurse practitioner, and the patient, but between and among the physicians and the nurse practitioners in our group.
You reminded me of something that I've heard time and time again this past year is that trust with the physician, trust with the patient is so.
Shannon, I always say this, I tell a doctor, look, Dr. Decker, you and I just met. It's going to take me a little while to get to know your expectations and for you to get to know me and to trust each other. No different than if you had hired me as a nurse practitioner off the street to be part of your practice. So yes, that's going to take a little time. But once we're establishing and developing that mutual trust and respect, game on, Shannon. And that's what we really enjoy as clinicians. Because again, I worked for one of the home vendors. Again, I'm not here to disrespect or throw home vendors under the bus. There's real value in anything. As I always tell my parents who are constantly frustrated with folks who come to their home every year, I say, look, come on, you're retired. If someone's willing to come to your home and check your blood pressure, it doesn't cost you anything, and maybe you get a gift card. Why not? So again, I like to find the value in anything that someone offers. We like to think that we offer so much more value, but again, it's the value that we feel as nurse practitioners where we're building relationships, not just with the patients, but we're not running in silos, just doing home visits all day long and know there are other NPs out there that we'll probably never meet. Instead, it's just the opposite. We're a very team-focused culture. We go out to dinner. We do charity events together. We get together with our physicians and have fun with them along the way as well. So again, it's the value proposition to all involved, and we feel good about what we've been able to bring to the table there. It doesn't hurt as well when that physician who's a little skeptical a few weeks into doing our work, I say, hey, Dr. Decker, I'm seeing patient Shannon next in my room. A little worried about her. She's in nuanced at AFib. And he said, really? And this is a real example, right? And there are numerous examples that could go on and on. And that's when the light bulb really goes off. And the doctor says, wow, Rick, whether they say it or not, I can read it between the lines that they were thinking it, that we're just asking questions like the traditional home vendor might often do, not always. Their light bulb goes off that, hey, they're adding real value to my patient's care and even saving lives here by finding things like unidentified atrial fibrillation, obviously uncontrolled hypertension. I'm thinking of Shelley, our first nurse practitioner. I think you may even remember Shelley.
Yeah.
So Shelley is an oncology nurse practitioner. We have a broad group of individuals. Long story short, Shelley as an oncology nurse practitioner, and because of the value at which she was doing with one of our physicians, who I think you know as well, in the Temecula, California area, was able to get a patient to get a mammogram done when that patient had consistently refused year over year because of the coaching, probably because of her oncology background to some extent, and the reinforcement of the importance of mammography. The patient ended up having breast cancer. And I'll never forget Shelley telling me that the oncologist called her and said, "Look, you saved this lady's life," right? Because she had never had mammogram. So again, one of many stories I could share over the years, Shannon, but that's what gives us great joy and satisfaction is we can do risk adjustment, coding and documentation in our sleep. I can do a retinal exam with my eyes closed. It's almost so easy to do that these days. But at the end of the day, what additional value are you offering besides just checking the basic boxes of coding and documentation, of closing a quality gap with a retinal camera, sticking a finger to get a drop of blood? What additional value above and beyond that are we offering?
I love that. Really appreciated spending time with you today. Look forward to more conversations in the future. I think that the industry would appreciate a lot of your insights that you've had in all the years that you've been in healthcare. And I look forward to having those conversations because, like I said, I've had the opportunity, the good fortune to work with you for many years. And I know that there's a lot more experience and stories that we can impart. So thank you.
Thank you, Shannon. Pleasure is all mine. And once again, great seeing you. And thank you for your interest in our group and our model.